The first question is that you had a wide in the significant evolution in the cardiothoracic surgery over the year. What do you consider to be the most transformative change in the field, and how have they impacted surgical technique and patient care? Additional, maybe what major change and development do you foresee in the cardiothoracic surgery over the next decade? Thank you.
My first mentor in cardiac surgery was Tyrone David, and he, of course, it was a pioneer for aortic valve reimplantation surgery, but also several techniques of mitral valve repair, and is still continuing to go strong, although I hear that he is going to retire next year. And he's obviously had a significant impact around the world. Another person who was a mentor of mine was Fred Moore in Leipzig. Also had an impact on a huge number of leaders in this area. And he took what I would say as the next transformative change, and that is minimal invasive procedures to become standard in Germany and across many other countries. And was really a visionary and an incredible person for moving our profession forward. So reconstructive surgery, one big change. Second big change is minimally invasive surgery. And then the third big change would be the increasing usage of transcatheter techniques. Although we as surgeons are not primarily performing many of these procedures, it is something that we need to obviously acknowledge that for many patients, this is a fantastic option, and is progress in the management of heart valve therapy. We always have to be, constantly looking at what exactly are the patients that are most appropriate for these techniques. But there's no doubt about it that for a lot of patients, this helps them with a quicker recovery, especially elderly patients or higher risk patients. And I was also had the great honor of being in Leipzig at the time that Thomas Walter and Fred Moore were doing the first transapical TAVI procedures in the world. And this was also, of course, a huge transformative change in our field.
As you think, who should to be done by from to the structural heart disease like cardiovascular surgeon or cardiologist or the interventionist?
So at our center, we have both professions, cardiac surgeons and interventional cardiologists, performing all of these structural heart valve procedures. Although I know that we tend to be more of an exception in that regard, that the interventional cardiologist is the one who is either performing these procedures alone or is driving the procedures in many other centers in Europe and in North America. Not so sure about Asia, but we find that the presence of the surgeon is very important in order to contribute our knowledge on anatomy, physiology, and decision making for the patients, but also, of course, as backup in case there are any problems. Although the number of patients that experience severe problems is decreasing over time. But I also find that this is an important area for cardiac surgeons to work in, especially at the beginning of their career of operating on their own. There's many techniques that we can learn from our interventional cardiology colleagues, the guide wire skills that we now use for our conventional operations. For example, all of our minimal invasive mitral valve operations we perform with percutaneous cannulation of the femoral vessels. And these are skills that we learned from our cardiology colleagues. And now we, as the surgeons, use them almost every day in Leipzig in the operating room. The surgeons in the structural heart valve procedures in our hybrid room, they will alternate with the cardiologist. So the cardiologist may do the more complex procedures, but especially when we're working with cardiologists that are not stationed at our hospital, that come from other hospitals to come and do the procedures at our hospital, then these surgeons play a very important role and oftentimes are doing the procedures themselves, because the cardiologists from the other hospitals are not as familiar with these techniques and not doing them as frequently as our own cardiologists from our own hospital.
Okay, so thank you. But I hope that maybe in the future, the whole team might be all the way better, because we can together support and to take care of the patient better. The Leipzig Heart Center is renowned for its own innovative approach to the heart surgery. Could you highlight some of the most innovative technique or technology currently being utilized in the Leipzig Heart Center? Furthermore, could you share the detail about your current research project? Thank you.
Yeah, so Leipzig Heart Center has a long history, even though it's not a very old hospital. We're just celebrating our 30th year this year. It was founded in 1994 as a unique collaboration between a private hospital company in Germany and the University of Leipzig and the state of Saxony, where we're located. And that was under the vision of Professor Fred Moore, my predecessor. And he was very, very innovative and very forward-thinking about how to advance our specialty. So as I said before, he, together with Tommy Walter, performed the first successful transapical TAVI procedure in the world. Also performed one of the first robotic mitral repair operations. In the meantime, I think we have the world's largest experience with minimal invasive, so endoscopic mitral valve repair surgery. We also have one of the largest experiences with mid-cab surgery. This was also another area where Professor Moore really was trying to encourage us to think of ways to operate on patients without the trauma of performing a full sternotomy. And mid-cab is just a standard procedure for us. We've done over 3,000 of them, and with very, very satisfying results. But what we've now extended into is something called mixed cabbage. So we have a couple of surgeons that are able to do this highly specialized technique where through a small left mini thoracotomy, we harvest both mammary arteries, do a Y anastomosis within the chest, and then are able to do 2 or 3 or sometimes even 4 bypasses. Of course, without cardiopulmonary bypass and without manipulating the ascending aorta. So this is a really fantastic technique. The patient has no risk of sternal infection, essentially no risk of stroke because there's no manipulation of the aorta. And the patients are very, it's a very desirable procedure for the patients. On the other hand, like all of these minimal invasive techniques, it is technically more challenging and there's a longer learning curve, and therefore we're still in the development stage and trying to figure out ways to make this more generalizable and applicable for a wider group of surgeons and patients.
Okay, thank you. And could you share about more detail about your other time, the current research project from you other time now?
Our current research projects?
Yeah.
Yeah, so our current research projects in Leipzig, we have many of them. The classical retrospective studies in cardiac surgery, of course, we continue to do those because we have a large database, and I believe those sort of studies are a great way for young cardiac surgeons to learn the skills of clinical research. But at the same time, I'm a strong believer in evidence-based medicine. I've been involved on many different guidelines, and the fact is that these retrospective studies always suffer from selection bias, and therefore we are pushing very hard at performing randomized trials. Of course, for these randomized trials to be effective, you need multi-center participation, oftentimes international participation. So you have to be able to work with a large group of investigators. And these are skills that I'm hoping my younger surgeons are learning now. But for example, we're playing a prominent role in several CTSN sponsored studies, including PACES and REPEAT and primary. And these are the way that we're going to advance our specialty in the future in order to demonstrate conclusively that the therapies that we are doing are beneficial for the patients, rather than just simply with retrospective studies with all of the downfalls of those. In addition, we do have some basic science research programs going on, and one area that particularly interests me is the effects of mitral valve prolapse on myocardial fibrosis, and how that can unfortunately translate into ventricular arrhythmias and even sudden cardiac death in patients with mitral valve prolapse, how we can prevent it, how we can optimally treat it, because I believe we as surgeons are perfectly positioned to treat this problem, because we can restore the normal biomechanics of the mitral valve with a surgical repair and return the patients to their normal lifespan. Whereas we don't know if the transcatheter techniques are going to be able to do this. But these are things that we're actively looking at right now.
What are some of the biggest challenges currently facing cardiothoracic surgeons, and how do you and your team at the Leipzig Heart Center address the challenge to ensure successful outcome? Thank you.
Yeah, so one of the biggest challenges is, as I alluded to before, that the transcatheter techniques are being used more and more frequently, and that we as surgeons are the profession altogether is shrinking slowly, not massively, but slowly. And a lot of the patients that we are treating are further along in their disease process because they've undergone some form of transcatheter therapy before. And I believe that there are limits to transcatheter therapy where we are definitely offer better therapy, complex coronary artery disease, mitral valve regurgitation, so primary mitral valve regurgitation, particularly in non-elderly patients, aortic valve reconstruction, complex ascending aorta arch disease. I think we can offer a better solution than transcatheter techniques in all of these areas. However, we have to acknowledge that our therapy is more invasive. So it's more invasive, but it's more effective in the long run. But obviously, the effectiveness of these therapies is highly dependent on the safety. And if we have a poor outcomes around the time of the procedure, then the patient will never be able to experience the effectiveness of the procedure. And that's why safety always has to be at the forefront, and we can't just be experimenting with new procedures that are unsafe for our patients. So this is the biggest challenge from my point of view for our specialty, is to try to find the balance between innovation and moving forward with our profession while not compromising patient safety and ensuring that the patients benefit in the long run from our invasive therapies.
Could you please discuss the key point for the managing cardiac implantable electronic device associated infective endocarditis? Because I think a lot of the cardiologists want to be here about you.
Thank you. Well, I recently co-chaired the European guidelines on endocarditis, and CIED and associated endocarditis are a particularly challenging patient population. The number of these patients is increasing because we are implanting more and more pacemakers and ICDs and other devices that can get infected. And these patients have the worst outcomes, even worse than left-sided heart valve endocarditis. They tend to be older and sicker, but also they're complex. And what's very important is first of all to make the diagnosis, because it's oftentimes quite challenging. On the echo, you may see something on the pacemaker lead that's floating around, but you're not sure, is that a vegetation or is that a thrombus? And therefore, the advanced cardiac imaging techniques such as CT angiography, PET CT especially, or white blood cell SPECT CT, these all play an important role in the diagnosis of CIED associated endocarditis. And then once you are sure that the patient does have this problem, then the entire device has to be explanted. You can't just take out the pacemaker and leave the leads in. The leads and the pacemaker all have to be removed completely. And those are for patients with definite CIED endocarditis, but even with patients with suspected endocarditis where we're not 100% sure, for example, with recurrent gram-positive bacteremia, in the guidelines we said even for these patients you may want to proceed with taking out the entire device, because making the diagnosis can be quite challenging in these patients.
And the last question, what advice would you give to the medical student and the young surgeon who aspire to the specialty line in the cardiothoracic surgery, especially those who hope to contribute to the field in the way you have it? Thank you.
Thank you for that question. It's a great question. We are constantly trying to encourage young, talented people to go into our specialty, but at the same time, I make sure that they understand some of the important issues and challenges of our specialty. They have to be people who are intellectually inquisitive, so they always have to be asking why and what is the reason behind this, and how come this is the solution and not that solution, and how can we do this better. You always have to be challenging yourself intellectually in our field. Otherwise, you will not succeed. Then you have to like to work with your hands, obviously. You have to like to help patients, but at the same time be able to cope emotionally with occasionally losing patients. This is one of the toughest things in our profession, is that when we do an operation and it goes badly, and sometimes even the patient doesn't leave the operating room and you have to go and talk to the family, the fact is that the very next day you have to come back to work and do it all over again. So I make sure that the young people realize that this is a challenge, especially in the early parts of their career. I also stress that they have to be honest. You can't pass on information in the hospital that is not true, because that will definitely jeopardize patient safety. And then finally, I just want to express to the young people that they have to be good at making decisions. Not every decision is correct. It's normal as humans to make mistakes, and sometimes our patients will suffer from those mistakes, but the most important thing is that you learn from those mistakes. In our profession, it's totally fine to make a mistake and learn from it. But if you make the same mistake 2, 3, 4 times, then you've chosen the wrong profession. You need to, in general, make more correct decisions than wrong decisions, and you also have to be able to make them relatively quickly, because in a cardiac surgery operation, we have to make many decisions. And if you take too long to make each one of them, the cardiopulmonary bypass time and the myocardial ischemic time is way too long, and the patient will suffer from that. So these are sort of the characteristics that I really try to stress to young people who are interested in this field, so that they have a good idea of what they're getting into. But at the same time, I say to them, it's the most satisfying job possible from my point of view. You get to help patients routinely, but it's a lot of hard work. But I couldn't think of a better profession to do.